All right. Hello and welcome to another Down Fracture podcast for talking jaws. Per usual, Dr. Michael Wasson, Arizona Jaw Surgery, here with Dr. Sam Bobek of Seattle Jaw Surgery. How's it going, Sam?
Good, Mike. It's good to be here. We're talking
Is it?
about, yeah, I think so. I like talking about topics. We're hitting a topic based off of an email request, right? Someone brought up a question.
Yeah, so this was one of the topics we've been kicking around doing at some point in the near future, anyways. And then we got an email request for this topic that showed a case and some other things involved in it. So it seemed like a logical progression to go this way, especially coming off the non-union talk from last week. Now, as our usual basic housekeeping here, downfracturepodcast at gmail.com. Email us because, as you just heard, we do read it, respond, and take it under advisement. And then I would also say, Sam, we have a little bit of congratulations in order. We are now over 200 followers, which puts us just behind Joe Rogan as
Yep.
far as
Yeah. Big time.
podcast numbers, I believe.
Yeah. I mean, I don't know. I think it's good. I think it's good to have people listening. So it's fun to talk about this stuff. So we'll just keep it going.
Yep, keep it going as well as long as we can. The other bit of housekeeping, I was re-listening with our producers. I was re-listening to last week's episode, and I want to clarify something because it seems like at the last little bit that we were talking about, maybe there was a little disconnect between the two of us because I was starting to talk about how we revise or treat non-unions with a little bit different perspective. And I think you thought I was talking about distraction or SARPE, dome, whatever we want to call it these days. So point I was trying to make from last week towards the end was when you have, the non-union and you're trying to figure out why, or if you do figure out why, or let's say you attribute it to a large or aggressive movement, what I was trying to convey is there's always this attitude of, hey, let's do something different the second time. Like, hey, what we did the first time didn't work. So, okay, this time let's take hip or let's do BMP or let's aggressively bone graft or let's keep the splint in longer and not have them chew for longer. Like, you just kind of throw everything at it. But I was trying to get your thoughts on, do we need to do that? So, like, let's say, statistically, non-union happens 5% of the time. Let's just throw out a number here. And now it happened to you, and let's say it's 10% on a revision case. So now we have what, 0.05 times zero point 0.1 is the likelihood you're going to get, a non-union the second time. So maybe not likely that you're going to get it. And also, part of the reason maybe you had a problem the first time was it was a large movement, expansion, advancement, whatever it may be. And now you've kind of overcome that barrier to an extent because you probably got some expansion or some movement. You've stretched out the soft tissue. You've battled some of the interferences and other things. And so, in theory, almost that second time, from a movement standpoint, should be a little bit easier. While there's other variables that make it more difficult, is it logical to then just say, okay, well, let's just treat it like it's the first surgery. Let's just cure at it and treat it normally, and we let it ride. Or are you feeling like you got to throw everything at it?
Well, I don't think you need to throw everything at it. Have you had many third surgeries? Have you met people on surgery 4 or 5?
No.
Those experiences will make you want to not have third surgery. And so, I just kind of look at it as I'm not entirely sure why non-unions happen. There's some ideas that are out there. I'm always suspicious. It's a few things, and one of those is the amount of expansion. Um, if it hasn't healed, you haven't really achieved the original movement, right? Like it's not healed in that location. And so I feel like coming up with some alternative ways to hold it there is correct. And I mean, I might be just treating my own kind of concerns, right? Like it could very well be that you're correct, that you can just do traditional hardware. It's just, you know, second go round, it's like, well, you know, let's approach this a little bit differently. And I think
It's
that's going to
logical.
be okay.
It's certainly logical. What we did the first time didn't work. Why would we do the same thing again? But you do that same thing all the time and you have a low incidence of
Yeah.
non-union. So like why is it wrong sometimes and right sometimes? Like
Yeah, I mean, I don't know. I would throw out there it's kind of like dental implant failure, right? Like dental implant failures just happen. They seem like they come up in batches. Like the people who get failures have a few failures. And it's like, well, what's going on here? Why isn't this like looking at it differently with fresh eyes is reasonable.
definitely. Okay.
Yeah, I think, yeah, you're right. I was listening to something else. So my
Well,
bad.
that, I mean, that kind of
Thanks for
naturally
clarifying.
takes us in to today into the email question, which so we did get an email question about requesting some, maxillary expansion as a topic. It's not the first time. I think we've gotten that request a couple times that it's been on our radar. But one of the questions in that was, hey, how do we feel about the kind of classical teaching of anything beyond maybe 8 to 10 millimeters you need distraction in the realm of maxillary expansion, or do you feel like you can consistently, predictably do more than that? And so, where I know the answer to this question from you, but where do you stand on that for our listeners?
Well, yeah, because maxillary expansion, I think, is a big topic, and I think anyone in practice hears about this a lot because there's a lot of non-surgical expansion and in orthodontic world, maxillary expansion, particularly in the realm of sleep. There's a lot going on there, but the conventional wisdom coming out of residency and fellowship, I found it strange to ever do a SARPE or now a dome procedure, distraction procedure in the maxilla. Um, because I guess I was experienced to world of being able to achieve just about as much transverse expansion as you can. I think I would take a step back, and actually the two groups are different groups, by the way. I think the people who need SARPE need arch length, and the people who are fine with the segmental Lefort, whether it's a 2, 3, 4 piece, need transverse width, right? And so the patients that you need, like they have a lot of crowding, or you need to open up space for dental implant reconstruction. Those are dome patients because you can't create arch length with the segmental Lefort. And so now I think it's more of a, why is it necessary to change the transverse? And making the decision based off of that seems to drive it more so than the absolute. Because I think, I mean, in the transverse, I think the other complicating factor on segmental Lefort has to do with palatal depth. So like really shallow palate um, is really hard to change in the transverse. Like doing a 2 or 3 piece Lefort with basically a flat palate, you're really limited in what you can pull off. And maybe in that world, you're limited in like 10, 12 millimeters. But in a normal or a high palate, I mean, I think you can get 17, 18 millimeters. I don't think that's crazy at all.
You
Um,
think 17 to 18, huh?
I've pushed. I feel like that's a ceiling for me right now.
Coward.
I
Why
I
not
think
go
when it
further?
comes to that, so I don't think it's an absolute movement because the other way is, well, let's say it's a 12 millimeter movement, right? And they don't have any crowding, and it's an arch width discrepancy from the maxilla to mandible, and you don't want to do segmental mandibular surgery, right? So you're going to do a segmental Lefort to widen the upper arch. The concern there, and you're pulling up a case that looks like surgery first 3 piece, and they have a big arch change. So the idea here would be just managing the arch at the time of upper and lower jaw surgery, or doing a SARPE as a first stage. But that's 2 surgeries, and so it's kind of like falls into the wisdom teeth discussion that I'd rather just have it one surgery in my world. What about you? Do you have limits in your mind?
That's a good question. I would say, when I came out of residency, my thought process was very similar to the author of the email that we got. And I kind of was in that, hey, if we're at 10 millimeters, maybe even a little bit less, we should be doing SARPE. And that came from no firsthand experience of trying to do more and having complications, or I don't even recall, obviously I don't recall discussing it on individual cases all that often. Um, and then when I got out, I found that, when I would do 10, at first I struggled a little bit with experience. I felt like I was getting it, you know, it wasn't that big of a deal to get close to 10 or around 10. And then I guess to your credit, in the analogy I've used before that I think applies here is, the guy who ran the first 4 minute mile, and then within a year, six, seven, eight people had done it. Roger Bannister is his name. And so when you kind of hear the thought that, hey, you can do it, then I started trying to do more, and then I've been able to do more. I don't know that I would go 17, 18, like you. And one of my non-unions, as we talked about last week, was one that was close to 15. So I'm a little bit more shy than you.
Well,
But
so
I would go close to 15, I
because
think,
I would,
in certain
yeah. So I
cases.
mean, I would argue it's a little bit nuanced as well. So if we're talking about someone who doesn't have crowding, putting him through a SARPE procedure is going to accentuate their AP discrepancy. If they're we're the class 3, let's say, right? Like, because if they don't have crowding, unless you leave premolar spaces, which is just going to be a really long orthodontic approach, right? You have this big gap between the ones, and you need to close that orthodontically. So you've already put them through one surgery. And I know it's lesser surgery, but it's not like that much lesser surgery. And the recovery, I think, with maxillary expansion is a little bit longer than maxillary surgery anyway. But you put them through that, and then you then move their maxilla as a secondary surgery. This is kind of like the same argument on distraction, by the way. If they don't have crowding, why not just put them through the one jaw surgery? And if you don't get 17 and you get like 12 or something of that nature, just come back and do a second surgery. Because the alternative pathway buys them two surgeries for sure.
Yeah.
Right. And so, I mean, obviously, you don't want to compromise blood supply. You don't want to have tooth injuries or lose teeth or anything of that nature, which is what I think the concern is, right? Like that's the concern on the expansion.
Well, I think some of it is just being able to achieve it, right? Like, I
Yeah.
mean, I wouldn't take for granted, looking back at my own experiences, I was saying, I wouldn't take for granted that I'm going to get 15 if I'm trying to get 15. Like I don't take for granted that that's going to happen. Maybe you do. Maybe you feel that confident in having more reps, 30 years into your career, that I don't yet. And, that's where I think there's some strategy in having multiple plans, as we've discussed before, where
Yep.
you have discussed with the patient, hey, maybe we will narrow the mandible. Like we'll do maxilla first surgery, see if we can't get reasonable expansion, and maybe have a splint for 11, 13, and 15 millimeters, or whatever you want to do, or 17 and 13, and then narrow the mandible if you're not able to achieve it. Like, I think there's ways you can go and tools that you can utilize. But I think the way you phrased it, and I'm not sure it was as clear, but what you said that I think holds true is, with expansion in the context of dome or SARPE, if they still have another AP discrepancy or another discrepancy, like you're saying, that's a two surgery no matter what, if you put them through that. Whereas if you try and you come up short, or you have even a non-union, that bought you a second surgery, but it wasn't guaranteed. So you try for one surgery, and your backup plan is as good as what the alternative plan would have been, kind of
Yeah.
as you're saying it. So
Yeah.
to
And I
me,
mean,
that holds true. And there's
the,
some
the,
logic there.
I mean, it could be longer, right? Like it could delay orthodontics, like they're in treatment for longer in that path. But I'm not so sure. I know there's different places that always do maxillary expansion. And the idea is just put them through a SARPE. If you're suspicious of transverse, you get extra arch length, which is great. And then you can fix any asymmetry or incorrect position of the maxilla once you do two jaw surgery. And that way it makes your surgery easier. Did you learn that pathway? Was that a UW pathway or no?
No, I didn't. We didn't really do that, but I can recall guest lectures. There's some people who famously lecture on that.
Yeah.
Maybe not famously, but they're known to lecture on that. And they were also kind of, that's where I get that number two is, hey, 10 millimeters, you gotta put them through SARPE. And so I don't know. I think my opinion, my perspective has changed, and I used to do a lot more SARPE dome than I do now. But this one that I'm showing up here is one that I did recently. What
Yeah.
do you
So
think about this? So our listeners maybe
yeah,
can't see it, but how would you define this one?
yeah. So you have a 3D image up of a class 3 malocclusion with the big transverse arch discrepancy, like almost Brody bite on the posterior teeth. All of the mandibular cusps on the outside of the maxillary cusps. So to me, that says big tongue. I got to believe the human attached to that has some soft tissue that's pushing those lower teeth out. And you've already crossed off the list no to tongue reduction and yes to bony expansion. Is that right?
Correct.
And so bony expansion in terms of getting them out orthodontically, it would be great to tip those mandibular teeth in. But let's say you can't. I think expansion, like doing a dome, or I'm sorry, doing a SARPE here makes a lot of sense. There's
Yeah,
crowding
that's what
in
we
the
did.
maxilla. You're going to end up moving that maxilla a lot, though. I mean, if you move the mandible forward, um, is that an assumption? Is that wrong on the? Is this a sleep patient or no?
It is a sleep patient.
So you're going to move the mandible forward. What's going to limit their eventual MMA is the maxilla forward, and so I don't know. I think it's probably a good idea as well there to do the first stage maxillary expansion and call it a dome because it's airway centric. Um, the maxillary expansion in terms of airway is an interesting discussion because I think there's some nuance with all this in terms of the orthodontic and the surgical approach. I don't think it's like an absolute measured thing. I think it's, what are you getting out of it? And when it comes to maxillary expansion for breathing better, that's where that acronym DOME comes from. But there's also ease. There's also some surgical variants. I find SARPE as a procedure to be quite variable practitioner to practitioner.
As far as what osteotomies and techniques, is that what you
Yeah.
mean?
Don't
Oh
you
yeah,
think? Like
absolutely.
you talk to people about it, and it's like one of the more variable procedures in terms of technique. I mean, Sag and Chins, Leforts, there's a little bit of variation, but there doesn't seem to be as much as SARPE. SARPE's
Yeah.
everywhere.
How
So
do you do it?
So these days, SARPE, I like TAD based devices. So in terms of the appliance, I do like screws in the roof of the mouth. I think that makes a meaningful difference. I basically detach everything with the exception of the palatine bones. So I make I'll admit an occasional transmucosal incision like you want me to behind the maxilla, but most of the time I still come from above. Got between the ones, most of the palate, not entirely because of the access. Cut above, nasal floor, lateral nasal walls, just basically Lefort cut, with the exception of the palatine bones. So, how do you do it?
So basically, let me make sure I'm understanding. You basically do everything but down fracture.
Yep.
Okay. We talked about this not too long ago. Just actually, I think it was for this case, I was kicking around ideas. So like I can even show images for our vast visual audience. Um, so let me see what's a better way to show this. Well, maybe this.
Because
So with
yeah, same
the
incision by the way, just one
with
incision. There's a bunch of different techniques on this, so I just make the
yeah,
same Lefort incision. So go
that's
for it. Sorry.
that's what I was trying to show is with the transpalatal screws, which I'm in complete agreement with you. I like that. I don't like pushing and tilting on the teeth, but you can have a hybrid appliance where it's attached to the teeth and you have transpalatal screws, or you can have an appliance that's just bone borne and doesn't touch the teeth. And so kind of if you need some flaring of those posterior molars, you can have an appliance kind of more specific to help you with that. But I'm a fan of the screws. When I would say the patient habitus and size kind of dictates how I do this when I'm using transpalatal screws. So as on our screen, I'm showing a case I did years ago that has a hybrid appliance. It's fit around the teeth as well as has four slots on, two on each side of the palate for transpalatal screws. This was a mid 50s female who was not very big. And so in her case, what I did is I put in the transpalatal screws. I did my incisions different. I did three incisions to spare stripping the lateral nasal musculature. So two kind of Lefort level, vestibular incisions and a midline vertical incision. And then I do my Lefort I horizontal cuts and a midline osteotomy. And that's all I do. And then I activate the appliance. And then if that's sufficient to get the diastema, that's all I do. And then if it's not, then I go and I do nasal septum and then I do try again, activate it. If it's not working, pterygomaxillary disjunction.
Sure.
Um, but in this guy, he's this is a guy. This is a dude. This is one of those dudes that's not small. Like
Yeah.
bodybuilder, 6+, 6+ feet, 200 plus pounds, avid, weightlifter. So for him, I just from the beginning said, I'm not playing around. And then I did everything subtotal, just didn't down fracture it. But I do think with the screws, you get a little bit more force generation and it's kind of nice to sometimes take it in steps if you're not sure, and then activate it, see if you get expansion. Now, for him, I would say one argument against that I have in my head is asymmetric expansion. I think you're more likely to get that without doing the subtotal. But he's going to have a second surgery anyway. So if he's asymmetric,
I mean,
not
I've
the end of the world.
asymmetric expansion because I mean, I see people who do this without surgery just do the MSE technique, right? There's if people are unaware of that, there's a whole group of people that are really into expanding maxillas without surgery or minimal surgery. And so asymmetric expansion, when you talk to people who have a lot of jaw surgery experience, asymmetric expansion is kind of thought to be what you would expect. Like it would be weird to expect 50-50, right? Like 50-50 as an outcome can happen, but you kind of need to make up asymmetry orthodontically or through a second surgery. And so in these situations, which are like your patient, you're setting them up for eventual Lefort BSSO anyway. I don't think asymmetric expansion is the end of the world.
No,
Not that you're trying for that. It's just, like conceptually, it does seem strange to not get that. I mean, when I trained in Charlotte, they taught about making a horizontal cut at the anterior maxillary wall, cutting out a wedge at the buttress to prevent the anterior maxilla from catching underneath the zygoma, right? Like, because as you expand, the dolphin videos have a perfect transverse 50-50 kind of anterior maxilla, posterior maxilla are all moving the same. But I think in reality, that pivots around the posterior maxilla to some extent. So the screws do help minimize that, I think. They seem to be better about the posterior maxilla moving a little bit better, as much as the anterior maxilla seems to be useful for helping out with the asymmetry business. But I still think that expecting no asymmetry is kind of wishful thinking when it comes to maxillary expansion.
and
What do you do for,
it's hard to diagnose that in real time too. Um,
yeah, I actually have someone coming up I did expansion on as the first stage and clinically looked asymmetric, but we were really just bringing out her mandibular asymmetry and have her set up for the second stage surgery, and largely the asymmetry sorted out in the mandible. And so I think clinically it can be a little bit confusing, especially while they have a big diastema and the area hasn't healed completely.
Yeah, I mean, they got crowding in the lower sometimes, like this guy tilting of the incisors. Like that's what I'm just clicking back and forth here for those who are watching. Like he's a little bit to this side, but when you look here, it looks like he's expanded more to the left than the right. Again, in his
Yeah.
instance, I don't care because I'm gonna, well, I mean, I care about everybody. I care about humanity as a whole.
Yeah, no, I mean you probably care too much.
I
But
do.
the if you have little asymmetric expansion, let's say you have 100 and 0. Let's say you just have the right
One
side
side.
out.
Yeah.
What are you doing?
What am I doing? Well, in
Yeah.
this specific instance, I don't know that I'm doing a lot. I mean, I have talked to, and I have actually done it, gone back and revised the osteotomies to
So
try to
you're
free it
opening
up
up
more.
the incision on the side because you're making
That's
three incisions
non-moving.
here.
Yeah, the side that's not moving. If I didn't do certain osteotomies, I do those the second time.
Got it.
And I think I've only done that one or two times. But again, in his instance, I wouldn't do anything because he's getting probably a segmental Lefort down the road anyways, and I'll deal with it then. Like it's
Yeah,
just.
I
But
definitely agree as best you can during surgery, trying to get as much expansion to
I've seen
keep out.
orthodontists who are worried about it do cross arch
Yep,
elastics.
totally.
I've seen some things go down. Is that what you were getting at?
Well, yeah, and I've you know, ending surgery, you want to feel at least pretty good that both sides are moving. And after surgery, they tend to be okay, but then they come back, like 2 weeks or 3 weeks, and asymmetries showing itself up. I've sedated people, just done sedation, maybe not made too much of a surgery out of it to see if you can just get that to move a little bit, like a little fiber handle to see if you can unstick the maxilla. But cross arch elastics, even putting in a TAD to see if that can be helpful. Um, I think those like a little bit less surgery can be a helpful thing there. Um, what I was going to ask you though, with palatal screws, so the four palatal screws have been, I have orthodontists make those, so I just basically just defer to whatever they'd like. But I like the six palatal screws now,
Yeah,
the four
that's
palatal screws, because what can happen, or at least what I was seeing is you make your palatal floor cut, right? And it's easy to get off midline.
I,
Like mid pallet, it is easy to go towards those back screws. And you could be like, this is so straight. This is going to be perfect. If you're just accessing it from the anterior maxilla, I think it's really hard not to drift into one of those spots.
this is this is like odd. I had this case that I just did that's up. Um, had this exact same conversation with the orthodontist. I even had the sheet, so I got the name off here, and it's got the links, and it was the first time I'd used the six hole,
Oh yeah, the six is nice because they
which I
put two up by the
liked.
alveolus.
I really liked it, but I would say the most posterior screws were a little bit difficult to get to. But general anesthesia makes that not too much of an issue. But yeah, I like it for those same reasons because I had that same conversation of, he was just asking me about my technique. And we were planning where the holes would be and other things. And I had that exact conversation of, hey, I'd love to tell you I'm going perfectly straight down that mid palatal suture, but the reality is I may not. And even if I do, the split, like when I activate it, might cause a little bit of bone loss and other things. So if we can move them or have some screws a little bit further away from that midline, because that was the argument against the four hole that I didn't like this one
Yeah, because there's
for the
not that
reasons
much
you're saying.
room. And I mean, I think people definitely talk about, and actually the emailer had referenced it, just making palatal incisions, right? Um, so making palatal incisions, I mean, um, I can't remember what year, but I remember reading a paper either from Jessica or Dale. I feel like talking about probably Bloomquist, of making palatal incisions to access for that reason, just to be
Yeah,
able to locate it. So it's not a mid palatal, but a parasagittal incision, and then dissecting, making the cut from below, and then closing. The main thing that keeps me away from that is I don't want to have to seat the device. Like having the device in. There's already kind of enough moving parts when it comes to a SARPE that I don't know. I'd be interested to hear what other people thought of that one. But have you put the device in? Have you approached it that way and then just put the device in at the same time?
that's kind of a hard stop for me. Like, I mean, I'm willing to be flexible and work with people, but I mean, the reality is this: like, I don't need to be the one doing that. Like, the orthodontists are so much better at that
So
than
much.
me, but
Yeah.
I just don't
So
want to mess around with it.
yeah, so I think the newer designs with a couple different tabs can be helpful. Asymmetric expansion. I don't know, but I've heard in terms of surgical technique, in Oregon we got exposed to the Canadians, going to North Carolina, just talking to people about it. Classically with dome, you keep the alar rims intact, with the idea of expanding the nasal floor better. I was exposed as a resident to just anterior maxillary wall cuts. That's it. And then the rest you can just expand with, not even a cut between the ones, which sounds crazy, but
That
you know,
is
there's
absolutely crazy.
there's scoring of bone. I'm impressed by the broad techniques when it comes to surgery. Which now that I've been in practice a bit, I still think that this is a hard surgery and it's one of the harder surgeries. I think getting SARPE to do right, you know, 95 out of 100 times, is hard. because the anatomy and what you think is happening and how hard it's holding on posteriorly and just how the expansion goes, I think it's a tough operation to do on its own. But in preparation for a secondary Lefort, that's nice.
It is. It provides you a lot more flexibility, you know, less worry for sure. Um, I was going to say something now. I forgot.
Where I
No,
was
so
gonna say, in terms of the secondary Lefort, I think it when people have maxillary expansion, it doesn't feel like a revision Lefort, but it kind of feels like a revision Lefort. Like there's definitely scar tissue. It's definitely like a different surgical site than just a primary upper jaw surgery, which would be an argument against just a routine maxillary procedure. And I don't think it's a guarantee that you won't have to do segmental mechanics on your secondary Lefort either.
oh no, absolutely not.
So, the original reason for like doing it, obviously, if you need it for crowding in the arch and you can't manage that with like IPR or taking out premolars or something, then SARPE is the way to go. But I feel from the breathing perspective, um, it can be buying two surgeries. So just as long as everyone's on board with that idea.
What's been your experience with some of this expansion stuff? Because when I was doing more of it in the past, and orthodontists would ask me to put in, I mean, even some dentists were doing it and asked me to, they wanted me to put in the transpalatal screws, which was fine with me, not a big deal, whatever. But I felt like I saw a good chunk of people back, and I got to the point where I pretty much counseled every patient that I put screws in. I'm like, hey, if this doesn't work, you need surgery. Like we're gonna
And,
have to make
and
osteotomies. Did
you mean
you?
just MSE, the maxillary
Yeah,
skull expansion?
yeah, and maybe there's someone out there who has more experience. Maybe that's an orthodontist question. But I felt like when I was doing more of it, we got to the point where if they were an adult male, we wouldn't even try. Like we would just say like, there's just no way. You need dome. You need actual SARPE dome osteotomies. Have you seen just
Well,
the
because I
maxillary
mean,
expansion? And
I'm
it,
trying to think what the history of this in terms of the timeline. I think the years fly by, right?
yeah,
Um, because everything was SARPE and then Dome was probably like 2012 or something like that, maybe 2014. Um, and then it seems like MSE came around that same time. So maybe we're coming on 10 years of palatal screws.
probably getting
Uh,
there
I feel
for it
like
to be
that's
more commonplace.
because the original, or at least my understanding of the original orthodontist of Juan Moon, who kind of pushed that, and still does, with maxillary expansion with skeletal anchorage. It's been defining in terms of the patients who it's appropriate for, right? Like, because initially it's like unclear who it can be done on, and I think you're describing like an older guy with heavier bone. That's just going to be a tough one to do without surgery anyway. Um, I think an older teenager, I think people with thinner bone, I still think older people in general they're the ones that I've seen at least. And I think in this topic, the people I've seen after maxillary expansion with just anchors and no surgery are the people who failed, right? Because they wouldn't have any reason to see me. So
Exactly. Yep.
that crew of people, there's likely a bunch of happy customers out there. I haven't come across them.
Well,
But
I guess from the perspective, I mean, I think more and more orthodontists and dentists and other people are comfortable putting screws in now. I feel like that's something that I've noticed over the past, 5, 10 years,
sure.
because a lot of the orthodontists I worked with originally, like they didn't really want to do that, which I understand.
Yeah.
And the patients didn't either, because even though it doesn't require it, I could sedate them and just put in some screws. They wake up, it's done, which wasn't a big deal. But I think when I was the one putting screws in and seeing them for follow up a little bit, I felt like the number of patients who had success was much lower than the impression you'd get by the worldwide interweb and social media. Like,
Oh, for sure. I mean that this topic I think is there's a discrepancy between the real life and kind of the virtual life. But there's definitely times I've seen people and I know practitioners that do a lot of this. And so just screw expansion of maxillas. I would defer to them. I think we could probably have somebody like that on actually to talk about it. The hard thing that I run into though is just really holding their feet to the fire on what specifics, right? Like how many millimeters are we actually talking about here? Are you getting 10 millimeters, 80% of the time? Is that maintained? What are we talking about? And I think
I
it's still kind
really
of, you know, not
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 well
clear.
defined, not clear. And that takes time, that takes data. I mean,
Sure.
hopefully we'll get there. I mean, the other thing that I would like to see, and I do think there is some of it, is purely the bone-borne expanders. Because most of what I've been exposed to also has a tooth component to it.
Oh
And so,
yeah.
I think you're getting some tipping, and
Well,
and I think they don't always like. I think it's a convenient overlook sometimes of, hey, look at this measurement, and we got 6 millimeters or whatever. And it's like, well,
I mean, I think there's
probably some
definitely a
tipping
jaw
there.
surgery world, people who do maxillary expansion, and definitely ENT world that just use those kind of like claw expanders in the maxilla. You know what I'm talking about? That look
Yeah.
like,
Hmm.
like you're going, I don't know, climbing up some
Yep. I know what you're
ice
talking about.
frozen waterfall type thing. And it's basically just expand the maxilla, allow the teeth to drift back into place, and then go back and see an orthodontist. Um, that's at least my understanding of that world of just maxillary expansion for breathing better. And I mean, I've seen people that just keep turning their device, and so they're like crazy overexpanded because they're just trying to get to breathe better. Um, so I think there are some people that are outside the care of orthodontics in that world. And again, that's an area of practice I don't necessarily do. I always do these with orthodontists. So I can't speak to the nuances of that, but it's definitely a thing.
Oh
Um,
yeah.
so I would say because that's like ease, right? Like the endoscopically assisted skeletal expansion.
Yep.
Um, so I think in the world of maxillary expansion, there's kind of the airway part, there's the non-surgical part, there's the minimal surgical, and then there's the maximal surgical. I don't know what you tell people, but when people come in for a posterior crossbite alone and they don't have crowding, I'm pretty partial to segmental Lefort. Segmental Lefort's an hour 15. Um, recovery is fairly quick. That's predictable
So wait,
surface.
you're saying no other discrepancy other than a posterior maxillary transverse discrepancy, like they don't need anterior
And no
posterior
crowding.
movement. You're
Yeah.
saying you would do segmental Lefort versus
A SARPE.
distraction.
Yeah.
Okay.
Just because
No, I'm completely on board with
I
that
mean,
too.
I'd stress about 10% problems, like a 2% non-union problem is a big deal. Maxillary expansion, it's just, there's, you still have the same risk of tooth injury. You still have the same risk of non-union. You still have the same risk of nasal bleeding. If we're doing it for a posterior crossbite and not arch length, it seems to be more predictable to just do the Lefort.
Well, you have so much more flexibility to an extent too, right? Because you're kind of at the vector of the expander, like that's determining where the position ends up.
Yeah.
Instead of, you can tilt, angulate, you can also decide, have some creativity where you make your osteotomies to make things fit better. I think you can just control it
Yeah.
better. Like I think you could say in that instance, you might even be able to do the segmental Lefort sometimes without orthodontics. You'd never promise that. But with the expander, they're going to have
But I,
orthodontics.
I think for whatever reason, I don't see that many of those patients, just because there tends to be other reasons, right? They're doing it also for breathing. They're doing it also for aesthetics. They're doing it, we're managing other things. And so there's with the different provider kind of preferences and patient preferences and online world, I think being flexible with this technique is something I've learned over the years. So um, I think I just I think a segmental Lefort, if you can just free it up, I think the tricks to freeing it up, which we talked about long ago, right? Wasn't that one of our early episodes of freeing up
I don't know,
Leforts?
but it applies here. You want to just get
Yeah, I
into it
mean,
real
I think
quick?
tricks on expanding upper jaws, for me, the posterior maxilla holds up. And so I know for you that doesn't hold up because of the way you do your osteotomy. But
Yeah, I do it correctly.
yeah. But descending palatine vessels, taking a curved osteotome medial to those guys, medial and proximal, will get that little attachment of the plates away, and then taking a kerrison on the posterior aspect of the maxilla and cleaning that up can really mobilize it. It isn't row disinfection forceps. I use Tessier's to get it moving, but I find just routinely kerosining the back of the maxilla to free it up. Using your fingers to help expand that, taking your time, you really can get a lot of expansion. I think that what we've talked about in the past in terms of embrasure wires to pull on the maxilla, to even dissect along the nasal floor a little bit on either side, as long as you're conservative about that to facilitate the maxilla or the palatal floor dropping a little. Those sort of things, I think you can free it up. So I would
So
say,
that's how you go about it. So I mean, there's so many different techniques that have been described, like undermining the mucosa with like a,
but that somewhat holds it up. It just seems like all the time it's the back of the maxilla that's holding me up. Don't you think?
I think because it's hardwired into me when I have a big expansion. I just kind of, before I even try, I do all of those things. And so I would say I need to probably look at it more, maybe even take it in steps and see where I feel like I'm being limited. I mean, that's how we were trained is we would kind of take a double-ended curette and kind of undermine the mucosa
Sure.
on that meat on the central island
I
segment.
feel like Tucker would say that. I feel like I've seen that slide to where you undermine on the palate. It just
Hmm.
doesn't. It seems like it's more held up behind the maxilla, and then the other spot that I'm always kind of thinking about with maxillary expansion is at the interdental cut, right? Like I'm using my thumb or my finger to support that because you don't want to like tear that gingiva, and then you have some vascular problem or something of that nature. So I think when it comes to it, it's definitely more feel. But attacking the back of the maxilla tends to be helpful. And kerosene back there is great.
And I've seen like people put wires around the molars and pull each direction. I've seen little spreader devices. You ever use any of those things?
Wires around the molars, spreader devices. Um, I guess the other thing that is pretty useful is when you're putting people in IMF, getting the rest of it via pushing on the maxilla, like grabbing your finger, like your index finger over the maxilla to tip it in. So
Hmm.
you aren't just relying on the appliances, you aren't just relying on your splint, because those two things can give up for sure. That you really like get in there and put your fingers on top of the maxilla to seat the splint in there. Um, I think with really big ones, working in the back of the maxilla first and then doing the anterior maxilla in terms of seating them in the splints, another seemingly useful trick. So
Wait, say that again. So you're
because
kind of taking your
you're putting people in splints and I don't know. I tend to
talking
just
about the
put
palatal
wire in
splint
front,
or like the intermediate or final
the
splint,
intermediate or final. So you put the palatal splint in and then you're just seating them in, right? Because the palatal splint doesn't mean you've achieved the transverse expansion that you're hoping for.
right?
Just means that at the teeth. And so when you're putting them in the final or the intermediate splint, is what I'm talking about. So rather than securing it anteriorly, just start working the back of the maxilla and use your fingers to help set those segments in. Does that make sense?
Yeah, I even use embrasure wires through the palatal splint
Yeah, totally. But what I mean is
as
getting your
well.
finger up above the maxillary step at the
Mhm.
level of the osteotomy to feel those things kick out because it's you're getting the teeth expanded, but you're not necessarily getting all the bone expansion you want, right?
Yep.
And obviously it needs to be freed up prior to that step, but making sure that kicks out is kind of I would say the other thing I've learned over the years. So, um,
Okay.
but I mean, maxillary expansion, it's always kind of interesting reading literature to make sure you're kind of understanding what's going on. And so I'm usually try to be careful to figure that out. Um, the last part of this, it's kind of, I don't know, I would say I don't know, but I'm suspicious. Is do you think there's a difference between these two for airway?
Oh man, I don't know that we have a good answer for that. Do you?
Yeah, I mean, this is definitely a topic that's in the realm of we don't know, but I mean, talking with people and reading about it, I mean, there's some reasonable argument for distraction. So for doing a dome like procedure, um, distraction, you get soft tissue expansion, right? So it's hard tissue, but it's also soft tissue. That you may get more soft tissue expansion on the floor of the nose, right? So maybe you're growing more nasal mucosa than you would with the segmental Lefort. Yeah,
Oh,
I
okay.
could
Yeah,
buy it.
I see what you mean. I guess I was trying to think in more terms of like MMA. Um, but yeah, if you were just saying, hey, we need maxillary expansion, going back to that argument of segmental Lefort versus distraction, is that what you're
Yeah,
kind of
so
getting
in
at?
MMA, right? Like you're this guy that obviously you did for expansion for the dental reasons, but from the sleep apnea reason, there could be reason to start with the maxillary expansion and then keep it a single piece in the MMA or just do a minimal. Me, I'm pretty prone to doing segmental Leforts and segmental mandibles even for breathing better. Um, but doing it as a first stage from an airway perspective is kind of an interesting thing. And I recently talked to someone who does about as much maxillary expansion for that. And he had an opinion in that way. I don't want
He
to speak
felt
for him, but um,
he was of
that
the
was my
opinion that
understanding.
he's of the opinion that there's a noticeable difference between the expansion types and how much airway improvement is for nasal breathing.
Well, so the benefit, one of the benefits of doing a first stage maxillary expansion is that you get more development of soft tissue in the nose. Doing a dome in a first step of an MMA procedure. But the comparison to a segmental Lefort, I didn't really get that was
Yeah,
nuance isn't there. So
there's I don't even know if that's the right question. I think there's two questions. One is there a difference, and how big is that difference, and does it warrant a second surgery?
yeah, because
Um, that's
yeah,
where it's
totally.
tough,
Yeah.
because if it's a 1 to 3, 4, 5% difference, and you're talking, you start with an AHI or an RDI of 50, and doing distraction first gets you down to 5, and doing only segmental Lefort gets you to a 6. Like, I don't know that you do that.
Yeah.
But
Comparing
I
the
don't
two
know how you answer that
groups
question.
is yeah, I think until we can really compare the groups, otherwise you're just talking, just kind of philosophically. But in the world of maxillary expansion versus segmental Lefort or distraction versus segmental Lefort, I think can't leave that little stone unturned. So
Yeah. And do you, on your big expansions, do you talk to the patients about possibly narrowing the mandible? Like, hey, if I can't get this expansion, I may do midline. If you're doing the mandible anyways already, do you have that discussion of I may do
yeah, I
midline?
think that's a good bailout. I mean, I'd like that as a bailout, but I don't do that frequently. I mean, it's really big expansion that I would have that. And I would probably already be doing that otherwise. And so it's a bit of an unusual case, and I have to believe that most of our listeners aren't too familiar with segmental mandibles and then have that as part of their normal treatment planning.
Well,
Uh,
that was kind of the reason is I would say that for those people out there, we got an email and the question of how much expansion, and I would throw that out there as, hey, if you're a little uneasy about the magnitude of expansion and you're doing a SAG anyways, have the conversation with your patient about a mandibular midline osteotomy and do some of the narrowing there. Have two plans, and if you get it, doing your maxillary surgery first, and if you get it and you're comfortable with it, then great, and you had a backup plan if you don't,
yeah,
and I
I mean,
think that's
I think that's a
reasonable.
great option.
Yeah, until you
In
get
your
more
case,
comfortable with it.
yeah, if you didn't have crowding and if you really needed like 15 or 18 millimeters, there is nothing wrong with doing a little bit of narrowing the mandible if it's otherwise moving forward.
Right.
The the person you'd have to get bought in on that would be the patient, obviously, because if they're doing it for breathing better, narrowing the mandible might seem
Yeah,
like it's wrong too. But
you have
anyway,
that issue, but
yeah, yeah,
I think that's very similar to, most of the time if you have a big AP discrepancy, you don't treat it in one jaw. And I think that conceptually can apply here
yeah,
and
yeah,
be
for sure.
used as
The other one popped in my head as we're talking about it. So segmental Leforts, because this seems to come up another one. So segmental Leforts, just so we're talking about the same surgery. How many segments of the Lefort are actually there? Like how many bony segments are there for you? Do you have four? Do you have three?
you're talking about the difference in how people say it's a 2, 3, 4, 5 piece or whatever,
No,
because
no,
they
no.
don't.
Because I mean, 2, 3 piece has to do with the segments of teeth, but the actual Lefort, do you make a paddle island in every case?
So you and I have talked about this before, and I know what you do, and I tried that. I pretty much make a palatal island every time.
Okay.
You don't,
So,
unless you're
I
changing the
mean,
incisor inclination, right?
Yeah, so only if incisor inclination is changing, because I want to kind of keep the posterior maxilla going along for the ride, you know? Because that's the argument against segmental Lefort for airway, by the way, is the posterior maxilla doesn't move as much. So if you're moving the maxilla 10 millimeters, you do some counterclockwise, that if you have a palatal island, that the posterior aspect of the maxilla isn't moving as much as the rest of it. So and it's more of a theory than it is like an actual problem. But I mean, it could be an actual problem, right? So I don't know. I
Maybe.
feel like there's probably some premise to it. I had just learned when I was a fellow to keep the nasal floor with the anterior segment, or at least entertain the idea of that. Like, why
Yeah, I
make
think, I
that
mean,
cut if you don't need it?
I think it makes a lot of sense. It's just in the instances where I have to go back and cut it, then I'm frustrated. So I just kind of feel like it's easier to just connect it really quick when I'm doing it. And
Yeah,
then
sure.
you get a little bit more segment play. I think you get sometimes some less interferences because you've created some space. Because I use a burr, like a tapered fissure burr. You use a saw, right?
Yeah, yeah. I mean, people use piezo, just different
Yeah.
techniques for it.
So, but I think creating that space between segments gives you a little, like sometimes you're removing interferences and other things. And I think sometimes by just doing that, the advantages are you don't have to go back and do it if you find you need it.
Yeah, and I
And I
mean,
do think it kind of helps eliminate some interferences that you would have to then address in certain movements, anyways.
for sure. There's a time I was convinced with segmental Leforts with Invisalign that you didn't make that anterior cut that the laterals would sit high. Like there's because that's the part that always kind of falls out of the Invisalign segmental Lefort splint is the laterals. Like a little lateral that's kicked up off the occlusal plane. I don't know. That stuff bugs me. So
Do you
anyway,
have do you have a name for that anterior cut? Do you have a cute name for that?
I mean, I learned that cut as the cut of death. Um, that's not too cute though. That sounds like
No. But
um
where did that come from? Where did that was a
that
Charlotte
was a
thing?
Charlotte thing.
And why do you call it the cut of death?
Well, because if you carry that osteotomy through the palatal mucosa, it has an
Why would you do
unfavorable
that?
effect to blood supply to the anterior segments.
Why
Um,
would you do that though?
well, I
Would
don't
you
think you intentionally do that ever, right? Like
have you
it's just,
have you taken under consideration not doing that?
you try not to have problems all the time. It's just that's what that was referenced as. And so they may have changed it. It's probably got a more family friendly name. But I mean, the concern is, and I mean, in practice, the problem with that cut, the anterior cut for let's say a three-piece maxilla is it's like the height of the palate, right? Like the edge part of your oscillating saw. And so um I think that it's not like that happens at a high rate, but it definitely, if it's going to happen, it happens there. So in
I
terms
mean,
of
using
palatal rents,
I think with the burr, you can help with that a little bit, having your
sure.
finger on the underside of the palate, feeling the vibration and feeling as that changes, listening to the sound changes. I mean, I'm
Yeah,
sure it's happened. I can recall, a couple times that I've gotten small little perforations there, but it wasn't a big deal.
it needs a cuter name for sure.
I mean, why not the cut of life?
I
Like make
mean,
a
just like
positive spin on it. Cut of freedom?
you're right. I mean, I'll have to noodle that one because it's needs some renaming.
Yeah,
Um,
cut of death just sounds,
brings the negativity into the
it
room,
really
that
does.
portion of the operation. So maybe we'll text Farrell about it or something.
Yeah.
Well, yeah. So I think in terms of maxillary expansion, it's appreciate the email. And I think it's a good topic. It's another one we'd like hearing from people about in terms of things we missed or some advice. Um, but I think your case looks like it did it end up pretty well. The one that we're looking at here with the three
Yeah,
cuts
this
that
one,
turned into
this one
one.
ended up, mid 50s female. We got, here's where is she? Yeah, here's like a week post-op, you know. Maybe a little asymmetric there. I don't know. I don't know. But it
Ended
was
up all right
expanding.
though.
What's that?
Nice. Ended up all right.
Yeah, she finished up great, just got that. I mean, you could see she's edge to edge posteriorly starting to get some expansion. They always say they can breathe better. I will say that subjectively, they always say they are breathing better through their nose.
Yeah, I mean, it makes sense to be better. Data seems solid on that one.
Yeah. I mean, I don't have a ton of follow-up sleep studies after just the expansion, but they do subjectively, say, hey, I'm breathing a lot better.
Yeah.
through my notes. So let's put a bow on this. Does that count as an old man saying? Probably
Yeah,
not.
I think it's good.
I think it's going to have
Oh,
to
wow.
for today, because that's all we got.
Yep.
And then, so you feel, in summary, I know it's always patient specific, situation specific. Making things simplified doesn't always do us a service, but generally, you view distraction as an arch length, like a tooth arch length discrepancy, crowding type thing, and to address true transverse, you feel like that's a segmental Lefort thing.
Yep. With the possible exception of sleep apnea patients
Would and maybe low palates.
and low palates. Yep.
Okay, think that's a good summary. Think
I
that
don't know. I feel like that's currently my
we're
opinion
not
on
gonna.
this. What about you? You got
Yeah,
you
yeah. I
back
think
up.
that's as I said, I've adapted my philosophy because yeah, when I was kind of getting to the 8-10 mark, I was telling orthodontists, no, we got to do SARPE, and now I don't. I'm kind of in the. You've convinced me both with the wisdom teeth and this aspect of do everything you can to make it one surgery, and so sometimes that's I would say for my big expansions in recent times, I have talked about narrowing the mandible. Like, hey, if we need to, we're already doing mandibular osteotomy. This doesn't delay when you can chew. It adds, maybe a little morbidity, a little, risk. You have to have those talks, but the
Yep.
trade-off is, hey, it's one surgery. And so that's been kind of my approach is try to get it done. But yeah, in this guy recently, I was on board with doing a distraction
Yeah.
first.
Cool. Yeah, I think the mandible segmental idea is a good one to keep in mind on these. So
Maybe we
sweet.
should talk about that one day because maybe
Yeah,
people
one day
aren't
that'd be
as
good.
familiar with it.
I like it.
All right.
That was a nice bow.
It was a nice bow. All right. Well, as usual, that was another Down Fracture podcast. Podcast for Talking Jaws, downfracturepodcast at gmail.com. We do read the emails. Thanks for it. Tell your friends and family members to follow us so we feel better about ourselves by having increased followers. Do you have Wanda today?
I do. Yep, she's here. She's ready to go for a walk. So
Why would you say walk? Now you just screwed yourself. She's gonna go crazy now.
yeah, no, she understands that word. English language isn't big for her, but she's got that word.
Hmm.
So it's good.
All right. All right, cool.
All
Well,
right, man.
see you next time.
Yeah, sounds good. See you.
That's it.